Thank you very much. At the beginning, I wanted to thank all of you for a very nice invitation to this Congress and to Guna Company. That's a great honor for me to take part in your Congress. It's a very interesting Congress for me till now. About collagen and its use in the pathologies of the musculoskeletal apparatus. I wanted to say a few words today about collagen intramuscular injections in myofascial pain in dentistry patients, because I'm a dentist and I'm working with patients with TMD, with temporomandibular disorder, suffering from muscle pain. We have prepared a clinical trial, a clinical investigation. First of all, let's analyze what kind of patients are we treating. So those are patients suffering from bruxism. As you all know, I think, bruxism is a parafunctional activity of masticatory muscles in the orofacial region. Bruxism may lead to many symptoms in patients and complications according to excessive muscle effort. Masticatory muscle hypertrophy can occur and can be seen in this picture of the man with the quadricep face. Also, bruxism may lead to dental complications like dental tooth fractures and implant fractures and prosthetic restorations damage. The very important symptom of bruxism in patients is headache also. It is connected with extensive muscle effort. As you can see on this picture, we have patients with such a big destruction of the lesions around the teeth, and we also have patients with muscle pain referring from the trigger points to different parts of our body, of our face. We are treating muscle pain. According to RDC TMD and the next DC TMD procedures, we are dividing temporomandibular disorders into different points, into different kinds. The most important for us in today's lecture will be masticatory muscle disorders. We are taking care of patients with point 2 and 3, so I mean myofascial pain and myofascial pain with referrals. What is a trigger point? This is a point in muscle tissue that is palpable, painful for a patient when being touched, and those trigger point is referring the pain to different parts of our body. For example, if we'll find a trigger point in masticatory muscle, a masseter muscle, and we'll touch it and press it, the pain will refer to molars, to teeth of the patient. Why it happens? Because in the trigger point, the hypoperfusion occurs, so that's not enough blood because of muscle contraction. A lot of contraction causes a lot of effort. A lot of effort causes anaerobical metabolism and the lactic acid accumulation in this masseter muscle. So that is the reason why it hurts. Additionally, there is a problem with ATP molecule that becomes very low level, so it's impossible to separate myofibers of the masticatory muscles. So the muscle cannot relax. Unless it cannot relax, it hurts, and it works extensively. This is all about phenomena about Travels and Simmons, a very old book about myofascial pain and dysfunction. We are still using it, and it's still very actual. Trigger points are hard to find, but in Sigdar article and his colleagues, we can read about the 3D Doppler examination when we are using ultrasonography to find trigger points in muscles. And as you can see in this picture, we can identify the points, we can check what the blood flow inside is, and we can diagnose it and compare it with the palpation in patient. Why collagen is so important in muscles? You all know it, of course, and we were talking about it today. This is very important because it builds the muscle tissue and also the tendons. As you can see, we have 4 kinds of collagen, fibrillar collagen, type 3 and 1, and network collagen that keeps all the muscles, all the myocells together. This is also very important during the regeneration of the muscle. I will say a few words about it in a minute. Around the myocyte, we have a special fibroblasts that are producing the collagen into extracellular matrix. So the level of the collagen in those extracellular matrix is very important in the regeneration process. Fibroblasts, like I've told you a moment ago, are producing those collagen, two types of them, to the endomysium and to the perimysium around the muscle. And the secretion is very important during the muscle regeneration process. Those are stages of muscle regeneration. All the process starts from the myofiber breakdown and inflammation, and later on the collagen stimulates satellite cells that are in the pool of muscle tissue, in the cell of muscle tissue. It stimulates them changing into myoblasts and later on into myotubes and new myofiber tissues. And this differentiation is very important to recover faster, to get a better recovery in a patient. What was the methodology of our clinical study? So first of all, we did get the approval from our bioethical committee, and we did register our trial and clinical trials. And we did also stand some aims of our study. So we wanted to check the efficiency of intramuscular injection of collagen and lidocaine to compare to pharmacological substances in decreasing the myofascial pain in masseter muscles. Who did we treat? We were treating patients between 18 and 80 years old with myofascial pain according to DCTMD, point A, number 2 and 3, so it was myofascial pain with referrals and myofascial pain without. We did find the trigger points in those patients, and we did inject the collagen into those trigger points. And of course, we did it by patient's agreement. We have a lot of exclusion criteria about orthodontic treatment, patients without teeth, about analgesic drugs, alcohol and drug addiction, about other disorders after traumas, radiotherapy, and with pain with dental origin, pregnancy, lactation, malignancy, severe mental disorders, and other contraindications for injections. And the study was designed according to a consort statement with all the declarations, Helsinki and a Conference of Harmonization. What was important? It was randomized, control, single-blind study, and it was a 3-arm trial. The study was performed in the year 2016 and 17. We did assess 102 patients. 52 of them were excluded from different reasons, and 50 of them were divided and allocated into one of the experimental group. First of all, it was Collagen group, the second one is Lidocaine group, and the third one is Saline group. Almost all of them finished our studies. We've lost 3, 2, and 2 persons in each group. And we were analyzing them during 2 follow-up visits. If talking about group characteristics, they were very similar. So the Collagen group, Lidocaine group, and the Saline group was almost the same. We had 37 years of age, 32 years of age, and 30 years of age in each group. And also the time of the pain patients were living with was similar. In the Collagen group, it was 30 weeks of suffering with pain. In Lidocaine group, it was 34 weeks, and in Saline group, 38. The clinical trial consisted of 4 visits. First, we were screening for those patients. On the first day 0 visit, we were analyzing the patient, doing the palpation examination, and injecting. This was the first injection of collagen, lidocaine, and saline. We were checking the VAS scale, the pain intensity, and we were checking the surface electromyographic activity. The same on the second follow-up visit, and on the control one, we were not doing injections, we were just checking the VAS and EMG values. Primary treatment outcome was the pain intensity. It was checked with a visual analog scale from 0 to 10 points. Of course, it was individual for each patient and very, very subjective. The secondary treatment outcome was evaluation of surface electromyography. According to CENIAM guidelines, we were checking the superficial electromyographic activity bilaterally with self-adhesive electrodes and reference electrode on the patient's neck. As you can see in this picture, we did it with special equipment, Neurobit Optima 4.0. We did register rest values of superficial electromyography and the contraction values. And we did analyze it in BioExplorer, a special software for this equipment. As I've said before, the electrodes were placed according to the special schedule and under the zygomatic arch at the very beginning of the origin of masseter muscle, on the mandible angle, the other one, origin of the muscle, and the reference one on the patient's neck. We were analyzing those data. As you can see, in this first picture up, we have a patient clenching her teeth with repetitive EMG recording. And on the other one, down, we have the record of the masticatory activity muscle during the contraction. The whole time patient was contracting his or her teeth very strongly. We did achieve those results, and as you can see on this picture, we have two sides, the right and left masseter muscles. We have values and average one and the maximum one during this examination. And those were data that were analyzed in statistical analysis. We did, of course, a sample size estimation with the force of 0.9. We needed 36 patients. It means 12 in each group. And the statistics was performed with SAS software. The statistical analysis was performed with analysis of variance. And we used Hartley's test, Cochrane test, Bartlett's chi-square test, and Moschly test. And the level of significance was, of course, 0.05. And what did we achieve? I will tell you in a minute. Now I will show you how we were treating our patients, because they were divided into 3 groups. It was a muscle collagen group, lidocaine group, and saline group. We were using collagen MD muscle for injections, lidocaine 2% without vasoconstrictor, and saline 0.9 as a control group. Skin was, of course, prepared to injection with special equipment and with a special needle and syringe, of course, a small one, 0.4 millimeters and 19 millimeters long. We were first checking the position, the place for injection with our hands, with palpation, looking for trigger points. And we were injecting a small amount of a fluid, approximately 2 millimeters, in few places, just getting back and inserting, getting back and inserting, approximately 1 to 1.5 centimeters under the skin surface. In 40 patients, in most of them, we did it unilaterally because they have unilateral pain, and in some of them, in 3 patients, we did it bilaterally. Of course, the insertion of the needle is dangerous, and you have to be careful, extremely careful, not to damage parotid gland, parotid duct, vessels, arteries in this region. So we are choosing the region under the zygomatic arch, in this part, and at the mandible angle, in two different points. We were injecting the fluids, the pharmacies, on the baseline visit and on the first follow-up visit, and we're checking the efficacy at the second follow-up visit. What results did we achieve? The primary outcome was a VAS scale and pain intensity changes, and the secondary outcome was superficial electromyographic activity. And the reduction of pain was observed in all 3 groups. So we did achieve a better situation in saline group. It was 20%, so not a lot, 25% in lidocaine group, and 33% in collagen group. So as we can see, The effect of injecting something into the muscle is very important, but injecting saline or lidocaine or dry needling or acupuncture lasts for a very short time. And when we are inserting something, some pharmacy that lasts for a longer time and gives better regeneration process, we are getting better results. So the reduction in collagen group was the biggest and the most impressive. On the second follow-up, and the reduction was smaller. The best results, the best decrease in the pain was observed between 7 and 10 days after the injection. We are also evaluating EMG, and we had painful and no painful side. So first of all, we'll talk about those painful sides. As you can see, the electromyographic activity was also diminished in the group of collagen, about 60% almost, 40% in lidocaine group, and only 14% in saline group. Just like I've told you before, the reduction was also the biggest in the first week till 10 days after injection. On non-painful side, where the patient did not have any painful symptoms, we did record plus values or just very small changes in superficial electromyographic activity. So nothing changed on the side where we did not inject anything. Of course, all the data were statistically significant and statistically important. The reduction, as you can see in those groups, is even plus, so it didn't happen. We had some adverse effects. First of all, it was the pain during the movement just after the injection, just a few minutes, about 30 minutes. Some edema in the place of depot, some muscle stiffness, and unfortunately, in some cases, we had some bruises in the masseter muscle region. But all those adverse effects were temporary and completely reversible, so I think they are not very harmful for a patient. In conclusion, we think that intramuscular injection of collagen is a very effective method of reducing myofascial pain in masseter muscles in TMD patients, which is for us a new technology and new technique for preparing a better life quality for patients with bruxism. We also had some limitations of our trial. Short period of observation and single-blind nature of the trial. But we are planning further experiences about collagen in myofascial pain, and I think I will have an opportunity to share it with you. Thank you so much for your attention. It was a pleasure.